connected as of now, so we should start this webinar. Good morning, good afternoon, good evening, depending on from where you are connecting to this webinar. This is a webinar organized by Stop TB Partnership and USAID on the opportunity of this C19 response mechanism funding that has been announced from Global Fund. In the next 2 hours, we will discuss about this. Let me introduce myself. I am Suvanand Sahu from Stop TB Partnership. And as our speakers will speak, we will introduce them to you. And when you speak or make comments or questions,
On va recevoir vos questions. C'est important pour tous les participants.
You have on the lower row a series of buttons where you have chat, share screen, record. Then you have a globe there. If you click that globe, you get the language. Please select your language. We have 3 languages here for this webinar, either English or Russian or French. It's very important that you first select your own language, and you will hear simultaneous translations in that channel only. So please do that. So now we will start because time is short. I would first request Ruchika Dityu. You all know her. She's from Stop TB Partnership, the ED. Ruchika, please go ahead.
Thank you very much for taking the time to be with us. A large number today, 82 or 83 colleagues. We are very pleased to have such a large representation from the national TB programs. As we said, you will hear this message reinforced a few times or several times along the day. We did this in a full partnership and great, absolute engagement from our colleagues from USAID, Washington, as well as in countries, with a very big desire of ensuring that we as a TB community and the country programs, less we in Stop TB, but or not at all us, but the country programs, the NTPs and so on are benefiting from this amazing opportunity generated or funded mainly by the US government, $3.5 billion that went to Global Fund, specifically for the development, for the support of C19RM. This work is also, we worked with our colleagues from USAID, but in amazing partnership with our colleagues from the Global Fund, Eliud and his team, as well as Mark Eddington and the others there that you will hear from everybody today. I just wanted to clarify that we have our WHO colleagues online as well with us. That is a collective effort, is not one part or another. Now, we had a brief interaction today to make sure that there is a clear message coming to the TB programs and partners involved in the TB response in the countries. The C19RM opportunity that is presented here today, you need to make sure that whatever you hear, whatever you are told, whatever gossip, whatever somebody from a country team comes to you, you need to know that it has this funding is available for 3 opportunities. One is to fight COVID. The other is to mitigate the effect that COVID has on the 3 diseases. And the other is related to strengthening the systems for health and communities in the countries. Tuberculosis, it comes across these 3 areas and it fits very well in each of these areas. So irrespective of people telling you, no, this is just COVID, you should not accept this. You will hear this from Eliud, you will hear this from Mark Eddington, you will hear it from everyone. It is very clear, spelled out in the documentation. Very clearly, TB fits into the how to fight COVID. There will be procurements there. And procurements there that at least, at minimum, you need to ensure that for TB, you secure in there protective equipment, masks, go for N95 masks, Don't accept that this is going just for one disease like COVID. TB is an airborne disease. We fight for protective equipment for a long time. Infection control equipment, all that package that you will hear about, and we know all about it. Ensure that that is present as well. Ensure that diagnostics, as you know very well, there are machines these days for rapid molecular tests, as well as for X-ray that apply for TB and COVID in the same time. Please make sure that these are part of the COVID baseline. And please make sure that is there captured in the list of requests that are coming and are going to the CCMs. For the mitigation part, and you will hear in detail from everybody here, there are a bucket of interventions related to bidirectional testing, contact investigation, as well as engagement of communities and civil society, as well as, very important, addressing stigma. The addressing stigma can be also part of the core piece related to the COVID. The last piece, the last bucket that C19RM is asking for is related very much to the strengthening systems and communities, and then here constructing communities that can fight TB and COVID in the same time, being two airborne diseases with similar symptoms and similar way of diagnosing and dealing with it, is something that we should have captured in the proposal. I'm sorry I'm entering into this, but we discussed this morning with our colleagues and especially from the Global Fund, and we want to make this very clear. And please, the way of getting these pieces into the applications is by you being engaged in the process for the C19RM application. In many instances, as NTP managers, you might not be aware, invited, engaged for whatever reason. We will not have time to deal with the reason now. But what we must have time to deal with, and I offer my personal support, the one of Stop TB, and I imagine my colleagues from USAID and Global Fund will say the same, as we are all in the boat. If you are not allowed to engage in this process at country level, if you are not invited, please let us know, because that should not happen. The last thing I want to make, we are under pressure at the time. Today, Global Fund put a press release in which they speak about the impact in Asia and Africa of COVID. And TB is heavily affected, is the highest, as you can see, 60% impact on people getting access to diagnosis and treatment, 60%, by far the highest. So we should not accept not to be part of these discussions, and we should not accept that the TB angles, as I just mentioned to you and you will hear today, are not part of this application. With this, I stop here because time is very short, and I apologize for taking longer, but sorry, thank you.
Thank you, Ruchika. So now we go to Sherry Vincent. I think all of you know her. She heads the TB part in the USAID, and USAID is co-organizing this webinar with Stop TB Partnership. Sherry.
Yes, thank you. Yeah. So good morning, good afternoon, good evening. I first want to say thank you to all of you, not just for participating in this webinar, but for all the work that you've done over the past year facing COVID. I know it's been very difficult. And as I say, the TB programs are the unsung heroes of the COVID response. Many of you were asked to respond and to work on COVID or the interrelationship between TB and COVID. And we know that a lot of the efforts has been due to your work. And I know this is another request, another urgent action that needs to be taken, but I think this is a really great opportunity. It's potentially the financing that we've said we've never had since, TB has only gotten 18% of the Global Fund resources, and there's a potential for TB to get more. The US government's contribution, the $3.5 billion, that is the majority of this, is part of a larger American response plan that was passed by Congress that is almost $12 billion. It includes a vaccine component, which this is not part of it. So that's going through Gavi, but also USAID will have significant resources, as well as some other agencies will have some, but the bulk of the resources will come through USAID. And so it's really important, as my first point, that you coordinate with our USAID colleagues on the ground, because this will be able to be like linked up and coordinated with other activities that will be coming down the pike as that money starts to be released shortly. So it is part of a whole big package. On the Global Fund, as Luchika has mentioned, you know, TB was affected more than the other diseases. That's the facts. We have the data, that's the evidence. The overlap between the two diseases as well, facts, evidence, you know, they're respiratory pathogens, airborne diseases, the interventions are similar. And if we are to prevent the next pandemic, we have to build on that platform. So if we're going to use these resources efficiently, we have to build on that platform. So I think when you're talking to your Minister of Health, I think when you're discussing with your colleagues in the CCM in country, that these are points that are really important to bring forward, because it's not putting TB or TB patients first, because it's the whole community. We are treating the community. It's making the best use of these resources, building on the knowledge and expertise that your programs have. So I think whatever we can do to help that, there will be need to be a focus. It's not, you can't do everything. So I think also figuring out what are your top priorities, what are you going to focus on, and really prioritizing those to make sure that there's adequate funding for that. And I think that's part of this webinar, to help with the focusing of what really are these things that we can get, as we say, the best bang for the buck. And that's really what we want to focus, so that we can actually end TB. This is a great opportunity. These resources are tremendous, and whatever we can do to take advantage of this to help TB patients. And then the last thing is communities. Communities are extremely important, as you all know. But I think it's important to work together. We're stronger together. We all have our comparative advantages, you know, as the government. I understand the role of the government to lead, but we cannot leave our communities behind. We can't leave civil society behind. We're stronger with them. And the better we partnership with them in proposals, the better that we'll have success. So thank you very much. I appreciate your time. And I look forward to the presentations and discussion. Thank you.
Thank you, Sherry. Now we will hear from Global Fund. First, we will hear from Mark Eddington. Mark Eddington heads the Grant Management Division of Global Fund. We have a recorded video from his inputs yesterday on a similar webinar. So I request Ricarda to please play the video.
So C19RM is really critical. As you're aware, the US kindly gave us $3.5 billion for the fight against COVID. We also have an additional 140,000 euros from Germany. We expect a few more donations, and so we're thinking that we probably have about 4 billion eventually this time around. The allocation letters went out to countries last week. There's still a couple trickling out, but we did get about 110, 115 out last week. That allocation that goes out is what we're calling the base allocation, which is 15% of a country's current HIV, TB, and malaria allocation. And then there's the opportunity for at least another 15% for countries that need it. I mean, we talk sometimes about the Lesotho Egypt scale. So if it's a country like Egypt, which gets a relatively small allocation from the Global Fund because it has a relatively small disease burden, but has a large population, we would expect them to get more in terms of above the 15% base allocation, because they'll obviously need it in terms of COVID. If you have a country like Lesotho, which has a pretty small population, but a very high HIV burden, therefore has a relatively high HIV, TB, and malaria burden, we would expect them not to get that much more above the 15% base. So just wanted people to be aware of that. The immediate push on C19RM for us is on the fast track ordering of commodities. We're aware it's been 3 or 4 months since we had funds to approve, and therefore there are a number of countries that will have urgent commodity needs in COVID, so particularly PPE, diagnostics, potentially oxygen at this point. And so that's the immediate push. I think in terms of how we want to do this, our board's been very clear that the engagement of CCMs, PRs, as well as the National Response Coordinator for COVID is going to be absolutely critical. We also want to see increased civil society and community participation and involvement. And again, our board has been very clear on that. If there are any questions, please, and you're helping countries do this, please just ask them to reach out to their country teams. I think stepping back, what I think will be great from the TB community is, I think the TB community, in the same way to some extent as the HIV and the malaria community, has sometimes seen this as a either or scenario. Either the money goes to COVID or it goes to TB. Either it goes to COVID or it goes to HIV. And I'd encourage us to take a different view of that. Right now, COVID is the greatest threat to the Global Fund's mission. And we sort of have to deal with COVID at the same time as we're dealing with TB, HIV, and malaria. So I would say, try not to fight COVID and resources going to COVID. I would focus on where programs for COVID and TB can mutually reinforce each other. And I think there's some huge gains to be had there, particularly for TB. And, as I said, we just had a couple of slides on bidirectional testing, which is a great example, I think, as to where both COVID and TB can help reinforce each other, particularly with a focus on increasing access for testing. We know that in most countries, for example, in Africa, that there simply isn't enough testing to really even understand the scale of the COVID epidemic. And I know that's also the same in some countries for TB. So I think that the focus of the 3.5 billion, as it is currently, a little bit more, we do expect a significant amount of that to go on procurement. So PPE, diagnostic tests, oxygen, therapeutics, such as there are effective therapeutics for COVID, and sadly there aren't that many right now. I think PPE could cover sort of N95, FFP2 masks for TB as well. It could also cover diagnostics, diagnostic machines, gene expert, etc. For TB and COVID, as well as X-ray machines, infection control equipment. A lot of those are sort of dual use. I think anything that is dual use makes a very strong case. I do think it's important, looking at the issue of increasing access to testing, that we make sure that we don't just buy equipment for capital cities and big cities, but we actually think about how we're going to increase access out in remote areas as well, which might mean smaller capacity equipment. I think also there's a great need to prioritize as these C19RM requests are being put together, not putting everything in, but really just sort of prioritizing. And that includes community health workers and civil society. I think, our board's made it pretty clear they expect to see more community interventions, more civil society interventions. And I think we really need to think about where those can add value, whether it's active case finding, whether it's community-led monitoring, whether it's whatever it happens to be, because I think we will be looking quite hard to fund strong approaches in those areas. And of course, also contact investigation, active case finding, treatment support and follow-up. All of those are places where community groups and civil society can be very, very effective. I think as sort of we at the Global Fund look at this year, at least in grant management and the country teams, it's very much about three things. It's about catch up from last year because we know that, particularly in TB, a lot of the targets were not there. Scale up, because the new grants are already on average about 20% more than they were in the last cycle. And then of course, C19RM. And so when you look at all of that, I think that the focus from the TB community shouldn't just be about looking at C19RM as a potential source of money, but looking at how together we're going to do this 20% scale up in the current grants, which is already a stretch, how we're going to together do the catch up on targets, as well as how we're going to do these mutually reinforcing things out of C19RM, where we can really help address both TB and COVID. But I wouldn't want to see all the attention of the TB community diverted to kind of how can we get more money out of C19RM at the expense of the catch up and the scale up in the current grants. That's obviously a personal opinion. I mean, you guys can, at the end of the day, you will do what you want. I think in terms of, if I had an ask for all of you, it would be to focus on speed here. We see COVID and C19RM as an emergency program primarily, which means that, we know that not all the data is going to be there. We know that there isn't time to take 3 to 6 months to put in an application or a funding request. This has to be done quickly. So like I say, the focus is on those immediate commodity needs. And then the first windows for funding request submissions start in mid-May, which is not a lot of time. But we really do think if this is treated as an emergency, that is enough time to get some good requests in. We'd like to see robust requests, as robust as they can be. Strong collaboration at the country level. Obviously, that includes civil society communities, as well as the COVID National Response Coordinator. And the thing about COVID is it's a little different in every country. In some countries, it's firmly within the Ministry of Health. In others, it's being pulled into the presidency. It's in different places. And so figuring out how we keep everybody informed is going to be really critical, as well as with, bilaterals, for example, such as the US government, which is also putting some significant amounts of its own money into COVID, as well as giving money with us. So we need to make sure that coordination is there, because we don't want to see duplication. And we also don't want to see unnecessary gaps that could be filled, as well as the advocacy and communication, which we all know is critical. I think we're all wary of COVID, we're all wary of masks, we're all wary of social distancing, but we've got to get there, and it can be easy at times for those of us who are living in countries or who might be living in countries where the vaccine rollout is going well and cases are going down, but I can tell you, even in Switzerland, that's not the case. And it certainly isn't the case in most of the countries where the Global Fund is investing. It's a different view if you're looking at it from Africa than if you're looking at it from another country where all of those vaccine rollouts are going well. So I'm gonna stop there, just to say, I think honestly believe we have no choice but to continue in the fight against COVID. We will never achieve the mission of the Global Fund and the 3 diseases, and we certainly will not be able to get back on track in order to meet the 2030 targets. And I know all of you are extremely focused on that in terms of TB.
Thank you, Mark. That was from Mark. And now we have Eliud. Eliud Wandwalo leads the team of TB advisors in the Global Fund. Eliud, please go ahead.
Thank you, Sal. And I'll be very brief. I think most of the message have already been said by Ruchika, Sherry, and Mark now. Good morning, good afternoon, good evening, colleagues. And I'm very happy to see you. And also thanks the coordinators of this workshop, Stop TB, and our colleagues from USAID. For me, I would just like to emphasize some few key messages. First of all, to all NTP managers and all TB stakeholders, get involved in the C19RM country dialogue and funding request. Why should you be involved? Ruchika has already said it. This funding is for 3 areas: to respond to COVID epidemic, to mitigate the impact of COVID on HIV, TB, and malaria, and support health and community systems. So mitigating TB, HIV, and malaria is a core objective of this funding. So get involved in the funding request and making sure you are part of this process. You are involved directly in the mitigating of the impact of COVID, but also on tuberculosis, but also in responding to COVID. As we know, TB has been disproportionately affected by COVID. Most of you are also working in TB, but also you were pulled out to support COVID. So you are central to it. So you need to get involved. TB also support a lot system strengthening, community strengthening, and also benefiting from it. So you are involved in all three objectives of this funding. The other key message is making sure that the dual purpose intervention and the investment which could support both TB and COVID, they are included and they benefit tuberculosis. Mark has already highlighted which type of interventions. The PPE, they will be central, even if not for TB, but for COVID, making sure that every PPE which is being planned is also supporting TB workers and community health workers who will be supporting TB. Diagnostics, infection control measures, contact investigation, stigma. As we know, TB is suffering a lot from double stigma. So in any case, at the minimum, you should be there to make sure that all these interventions, which are actually geared to COVID, they also support tuberculosis. And these are some of the interventions which are really promoted even with this C19RM investment. I just want to highlight a few key issues for you, and you will hear from the presentation which will be made shortly, that you really need to do a very thorough analysis of impact of COVID on tuberculosis in your countries. I know most of you have already done in your countries, but you need to have that and to present that during the country dialogue, because that will really give a compelling case when you are putting your intervention. This should be done not only at the country level, but also at sub-country level. You need to ensure that you are ambitious in your application. And we have emphasized in our allocation letter, currently you will have a base allocation, but you also you can put above allocation requests, which will be 15%, but you can go even above that. You can go even above 30%. The Global Fund, is also encouraging countries to be extremely ambitious. Make sure that TB intervention, which could not be funded in the base allocation or not funded through grant, they are also part of the above allocation. A number of countries have a catch-up plan or restorative plan or mitigation plans, and some of you have costed mitigation plans. Use them as a strong case when developing C19RM investment. If you don't have that, do quick analysis, identify activities which could go in the C19RM funding request or which could be funded through the grants. I think the important thing, don't miss this opportunity. Whether this activity needs to be funded through C19 or through grants, this is an opportunity to take a whole picture of your TB intervention in your country and ensuring that they are funded either through grant or C19 funding opportunity. I think if you have any question, reach out to our country teams, but also if you are in doubt or you are getting a mixed signal, also reach out to partners. Stop TB, I'm sure they will let you know the contact details if you want to get more information, or if you are in doubt what can be included and not included in this funding request. So I'll stop there, Sao, and I'm sure I will have time to answer your questions and also to respond to your queries. Thanks.
Thank you, Eliud. I see that a lot of people are typing in the chat and we will take them. I would also request those from Stop TB, Global Fund, USAID, if you can answer some of the questions in the chat, that'll be good. Because of the translations, we will also take some of them at the end and discuss them. So now we go to a set of presentations. First will be from Global Fund on how to apply, and very briefly, because there are a lot of documents that are there on the website, but Ketavan will just take us through very briefly, digesting them all in just 10 minutes. So Ketavan is from the C19RM Secretariat within the Global Fund. Please go ahead.
Thank you very much, and good day to everyone. I'll briefly go through the presentation because a lot has already been said by Mark and Eliud. I would want to highlight a few points. First of all, I do think we need to say again the big thanks to the U.S. government for $3.5 billion that was made available for the C19RM response mechanism, and I think the appreciation is for the. It's a statement of confidence in the partnership that the Global Fund is representing, because while the funding will be channeled through the countries who will be implementing the response, I think it will take all of us, including us, the Global Fund, and the partners on the ground to make this a successful response. In addition to $3.5 billion US dollars, Germany has made available another 140 million euros through this response. As you heard from Mark, there may be some additional funding becoming available through the course of this year. I don't want to repeat all the messages that have already been shared, but I do want to stress out a few key points, and I've looked at the questions that you had been posting in the chat. C19RM is building on the previous phase, but there are some significant important enhancements that we've made in this next phase. The allocation letters, by now, as of today, 125 allocation letters have been sent to the countries and multi-countries. So these are all eligible recipients, and these are countries and multi-countries that are currently implementing Global Fund grants are eligible to receive funding. And this includes transition countries such as, for instance, Romania. I saw the question in the chat. So the allocation letter includes a very important two points, among other important points, is that it gives an indication to the applicant how much they can apply as the base allocation, which is more or less what the country should be expecting to receive. In addition to the base allocation, which is 15% of the HIV, TB, and malaria allocation, the applicant is encouraged to submit ambitious above base allocation requests. As an indication, we've put at least another 15%, but as I said, the request should be ambitious, and it should really show what the needs are on the ground. So it can be above 15% of additional request. What is critical and important as we speak, the countries are now busy preparing the fast track funding requests, and the fast track, the main reason why this approach was introduced is to allow for urgent needs for health products to be responded on quickly. As we know, there's usually a lag between the time when the procurement orders are placed and when the products actually arrive in the countries. So to respond to this, to the urgent needs of COVID-19 health products, the applicants will be allowed to submit requests for the fast track applications. And the fast track is quite limited. It's for PPE, for diagnostics, for therapeutics, and specifically for oxygen support. As we know, oxygen support has been one of the areas which has been absolutely critical to respond to COVID-19. So we do expect to see some of those requests coming in throughout April. And then subsequent to the fast track applications, countries can work and spend more time to develop more complex interventions and submit their applications through the 4 submission windows, which will be mid-May, end of May, mid-June, and end of June. So these are the 4 submission windows for the full application. I must say the fast track is optional. The applicant may choose to come with a full request through the submission window and opt out of the fast track option, but there is a possibility for that. All the requests, as before, will have to be submitted by the CCMs. It's a requirement. The full CCM endorsement will be screened and is a must for all applicants. Engagement with the national COVID response coordinating bodies is also something that we have introduced now within this new phase. And in addition, national COVID-19 response coordinating bodies will have to endorse the COVID-19 control and containment interventions. And this is, it's important to understand why this was introduced, is that to ensure that the COVID-19 response is coordinated on the national level, and it feeds into and is well aligned with the national response. What I will stress out again, just a few more minutes, is, as I said, all current implementer countries, including regional multi-country recipients, are able to receive a C19RM funding. So any applicant who by now received the allocation letter, and we have about 3-4 which are going to be sent within the next few days. So whoever received the allocation letter is eligible for C19RM funding. It was already mentioned that the eligible investments fall within the 3 broad categories, which is COVID-19 response, COVID-19 related adaptation of programs to fight HIV, TB, and malaria, and then health system and community system strengthening. What the C19RM funding will not do is procurement of vaccines, will not be part of the eligible interventions, nor be primarily focused on vaccine deployment. I will spend 1 more minute. I do want to stress out the very important consideration of the implementation arrangements. The funding will be channeled through existing principal recipients and grants. And again, as was noted by the previous presenters, this is an emergency response. So we are, and plus we are basically using these funds to strengthen our response to HIV, TB, malaria. So it doesn't really make sense to establish new grants. And more than that, I think the time for establishing new grants, it defeats the purpose of the emergency of this funding. So the existing principal recipients, to the extent also existing sub-recipients, will be receiving the funding. In some exceptional circumstances, the PR may consider new sub-recipients, but the new principal recipient will be something that should be avoided as much as possible. And lastly, I do want to stress out the community engagement. The requirement of the CCMs to work with different stakeholders and engage in inclusive consultations and meaningful engagement of communities is a requirement for this phase, and it's absolutely critical to reinforce this this message. And we do also anticipate and hope that this next phase actually includes more interventions that are focusing on community system strengthening and health system strengthening, which are cross-cutting and are helping not only COVID response, but also long-term effects on the HIV, TB, and malaria responses in the countries. I will probably stop here and see if there are any questions that are in the chat.
Sahu, you are muted. We don't hear you, so let's go ahead.
Sorry. Yes, so thank you, Ketevan. The chat is quite active, and we will try to respond on the chat as much as possible. So next, we heard about the C19RM, how to apply. Next, we will go into some TB and COVID interventions that could be considered for proposing in the proposal. So first of all, I will go through a few slides to just make a few points on what are important TB and COVID interventions. So if you can see my slide, is that visible? Okay, so first of all, just to highlight the impact on TB, this is very clear. Stop TB Partnership and USAID went out with a media piece which said that 12 months of C19 eliminated 12 years of progress, and this was based on the case notification decline in countries, which was huge and kind of unprecedented. We have also information coming out of at least 2 countries where we see there is a threefold higher mortality if a person is co-infected with both COVID and TB. Around the same time, WHO also came out and put out data there, which said that 1.4 million fewer TB notified in 2020 when compared to 2019. And in addition to that, the estimates for mortality due to TB, WHO estimates 500,000 more TB deaths in 2020 than 2019. So that's a huge impact. Now, people often ask that a lot of people are dying due to COVID, but also we have to recognize that a lot of people are dying due to TB. Here is the data sourced from WHO from COVID as well as TB. In the period 1st March 2020 to yesterday, or maybe day before yesterday, this is the figure. If you take Asia and Africa, where most of the TB high burden countries and Global Fund eligible high impact countries are there, you will see the red part is the TB deaths far outnumbering the COVID deaths. So there is no doubt that TB has been impacted, and TB has been impacted, as was said by some speakers before, disproportionately higher than the three diseases that we are discussing in the Global Fund context. Now, I want to quickly point your attention towards some technical documents that are on the Global Fund website, and then we will hear some more presentations which will deep dive into a few areas that we would like you all to consider strategically. So there are three technical information notes that Global Fund has now. Number one is the C19 response mechanism information note. That has the pillars of the COVID response and how countries can propose interventions in that. The second document is very much focused on HIV, TB, and malaria, and we will focus today on the TB part. And this is about mitigating the impact of COVID-19 on TB, HIV, and malaria. The third one is also coming. It's not yet there. It's an information note on community systems and responses. Now, if you go to the first document, which is the C19 response mechanism, this is based on the pillars that WHO has articulated. Total 10 pillars. Vaccine is the 10th one, which is not there. Here you can see in one box there, taken from the document, the 9 pillars. Pillar 9 very clearly saying maintaining essential health services and systems. And this is the one that we will also talk a bit more on. How do we mitigate the impact on TB? There are also, because of the way TB and COVID manifest, there are similarities. Also in the response mechanism, there are several similarities. So a country proposal with this objective of C19 response mechanism can link some of the TB interventions into the pillars. For example, if you note, pillar 3 has contact tracing. We will hear more about it. I am not going into the details of it. Pillar 5, lab and diagnostics. We will talk here in the subsequent presentations about bidirectional testing. How do we test multi-diseases in one testing platform, TB and COVID together? Pillar 6 has airborne infection prevention and control. This is also an area that TB can connect to. So there are some commonalities here that we should look at. Then going into the second information note, which is on mitigating the impact of COVID on TB, it is organized into different parts. A few things I will highlight because of want of time. In diagnosis, very important, the bidirectional testing. I will not talk more about it because there's a presentation. Diagnostics are very important. This is an opportunity to scale up diagnostics that can help in TB, but also can help in COVID. Also contact investigation and contact tracing, there will be a separate presentation. Many countries, depending on their settings, have active case finding, intensified case finding campaigns. These are important things to recover from the decline in case notification that has happened. On treatment also, many things can be done. They are all listed there and more details are in the information note. I will not go into it. Just to highlight, a few in the prevention. Airborne infection prevention and control is very important. You heard also some people in the beginning talking about it, and we will also see how countries can propose something in that area that can connect to both TB and COVID. Of course, there are many other things that can be there for the sake of being complete. I have listed all of them. One area that we also need to think about is how do you adapt the TB programming to the new COVID context? And many things are mentioned there. Some important things there to note is community and home-based and people-centered model. People cannot be asked to come to health facilities in this context when you have a lot of restrictions related to COVID. How we can do that better, and many other things related to the way that the program is organized can be changed, including how we train people, going into e-learning things, how we deliver drugs, and so on. And the area of addressing fear, stigma, and discrimination is very important. And last but not the least, the real-time data is very important. And this is an opportunity to also learn from COVID. We saw, just to make a point, we saw how the data which is openly available in the public domain in India, case notification data on a daily basis, helped India to recognize this sudden decline in case notification when the lockdown was announced, and how India could plan to respond to it and plan a recovery plan quickly. And I think this is something that more countries can do. Just to conclude, a few messages. It is a great opportunity. We have been worried about case notification falling, but this is an opportunity. As you heard, this is an emergency situation. We need to act quickly, but we have to remember that this is strategic. We need to be very strategic. We cannot put all things there that are there in TB. We know that TB was disproportionately affected by COVID, but we also know that TB has perhaps most in common with if you see any other disease with COVID response. So there are a lot of things that can be done that can benefit TB as well as benefit COVID, and these are the things to focus on. Prioritizing is very important. We will discuss a few things after my presentation, which we would like you to consider for prioritization depending on your settings. So I would stop there. Thank you. We will go ahead with more presentations, and we will have the discussion at the end. So next we have a very important topic about bidirectional testing or simultaneous integrated COVID and TB testing. It will be in 3 parts, covered by Amy Piatek from USAID, followed by Wayne from Stop TB. And then at the end will be Srinivas also from Stop TB. So that will be the three speakers will cover that topic. So Amy, please go ahead. We can see your slides there.
Okay, great. Thank you so much, Sahu. So thanks again, everyone, for joining this this call this morning for me, this afternoon or evening. So as Sahu had suggested or had said, we're going to now present the diagnostics piece, which all of the presenters thus far have said is a very important and prioritized component of this this funding. The diagnostics piece and the combined testing for COVID-19 and TB is one of the prioritized interventions that we think will play a critical role in restoring and accelerating the TB services. So I don't want to repeat what Sahu had said. I just wanted to highlight a couple of things. So we're talking here about what we're calling simultaneous and integrated, also being known as bidirectional approach to testing for both COVID-19 and TB. So a simultaneous integrated or the bidirectional approach to testing for COVID-19 and TB should be implemented in countries with a high burden of TB. While we know that there are clearly other pathogens that have similar respiratory symptoms, the approach is focused on COVID-19 and TB for several reasons, and I'm just going to highlight a few here. The first is that COVID-19 and TB are respiratory diseases that manifest themselves with similar symptoms of cough, fever, and difficulty breathing. The key piece here for diagnostics is that currently multiplex or platforms that can test for different diseases, they do exist, and we are currently using them for the tuberculosis program and other diseases. and they can test for both Mycobacterium tuberculosis and COVID-19. Right now we have a significant network of these instruments, such as the Gene Expert, that are already available in all of our high burden TB countries. And then, lastly, both diseases require early detection and treatment to improve patient outcomes and to, most importantly, reduce transmission among contacts and within communities. So as Sahu has already laid out, and others before him, the C19RM technical information note, and I really highly stress to please look at this. There's a lot of really good information, a lot of good references, and there's a lot of information there on the diagnostics piece. And what also I wanted to highlight specifically when we're talking about diagnostics and the simultaneous integrated testing approach is the USAID and the Stop TB partnership did develop guidance for the simultaneous integrated testing for COVID-19 and TB disease for high burden countries that is referenced in the C19RM information note. So again, we're just highlighting here some of the broader pieces of this. But again, please take the time to download this and look at it carefully. It's really important to notice that this guidance, like I said, is general, and it must be adapted for use in line with the policies and guidelines of the specific national TB programs in our countries and the COVID-19 response. So I'm going to just very briefly in a couple of slides describe the diagnostic testing approaches that are within this guide. And like Sahu said, my colleagues Wayne and Srinivas will follow. Wayne will describe the diagnostic tests available and other options and considerations, and then Srinivas will describe India's experience with the bidirectional testing. So here, there are a few diagnostic testing approaches countries can employ to test for both COVID-19 and TB. And the first that I'm going to describe in general is what we're calling, like I said, the simultaneous integrated or bidirectional testing. So this schematic is in the guidance. So we're going to go through it very quickly here, but you'll be able to look at it in more detail. The simultaneous integrated testing for COVID-19 and TB. So how this starts is we really want this to start with when a person presents to a healthcare facility or provider with respiratory symptoms, including cough and difficulty breathing, for example. At that point, the diagnostic test for both COVID-19 and TB should be done at the same time. So we are advocating that you collect a specimen for COVID testing and you collect a specimen for TB testing at the same time. That is where the simultaneous piece comes from. We would also want to emphasize that this should really be done at the peripheral level. The testing should be done in facilities and with platforms that are as close to the person and the communities as possible. We know that this has been something that we've really focused on for TB. And we know that this is something also that has been seen as incredibly important for COVID, because of the fact that there are these lockdowns and people are unable, and specimens are unable to really move around the country. We advocate that, once you have these specimens, they are transferred to a diagnostic center that does have a multiplex platform. That's where the integrated piece comes from. There you would run the test for TB and COVID, returning the results to providers and initiating appropriate treatment. We understand that, there are situations where the multiplex testing will not be available. When that's the case, you should still collect both specimens and they should be referred for testing for both diseases according to the national diagnostic algorithms. Again, preferably at peripheral or decentralized locations so that we can increase accessibility and hopefully timeliness. And like I said before, the reporting of the results to both disease programs is absolutely critical. Simultaneous integrated testing is especially important for people who are at elevated risk of having one or both diseases, or who are vulnerable to unfavorable outcomes, including older populations, people with comorbidities like diabetes and COPD. And countries can also expand the symptoms that are relevant for countries, but they can also include people who meet the definition of having severe acute respiratory infection or influenza-like illness. There are also situations that would require us to test for COVID-19 and or TB. Now, while we really are advocating that countries prioritize the simultaneous integrated testing for COVID-19 and TB, we realize that there are situations where testing for one disease or the other should occur. And here we have some examples. So the first would be in testing for COVID-19 or TB comorbidity in people that are diagnosed with the other disease. So, since most countries are not currently carrying out simultaneous testing for both diseases, usually resulting in testing and diagnosis of either COVID-19 or TB. So as we've said before, given the poor prognosis of people with TB and COVID-19 co-infections, we really should be striving to test people diagnosed with COVID-19 for TB and to test people that have already been diagnosed with TB for COVID-19. And just to highlight that treatment of TB should always continue and uninterrupted, even if the person is also diagnosed for COVID-19. There's also the situation for when you would want to test for COVID-19 or TB in people that have tested negative for the other disease. So persons with respiratory symptoms that previously had tested negative for COVID-19 and not diagnosed as having COVID-19, they should be tested for TB. And people who have respiratory symptoms that previously tested negative for TB and not diagnosed as having TB should be tested then for COVID-19. This is my last slide, and this is just showing example algorithms that have been adapted from India for some of the situational testing. So situationally testing diagnosed TB patients for COVID and diagnosed COVID-19 patients for TB. There are other examples from some of our other countries that we can also make available for reference, but they pretty much follow these general algorithms that we have presented here and the ones from India. And like I said before, later Srinivas will give more detail about India's experience. I know that we've gone through this very quickly today, but like I said, this, and others have said, this is a real opportunity for our TB programs to not only expand the testing for TB, the rapid testing, but to be able to use these platforms to kind of cast a wider net for people that have broader respiratory symptoms, and hopefully we'll be able to identify not just additional cases of TB, but also many more cases of COVID-19 in communities. So I will stop there and now turn it over to my colleague Wayne, who will provide more information on the specific diagnostic platforms. Thank you.
Hello, everyone. Let me just share my screen. Seconds. Okay, I hope you can all see it now. So as several presenters have already said, there's a lot of opportunity with this new funding to strengthen diagnostic networks, which is really important for TB, given the significant decreases in case finding in 2020. I've been asked to give this presentation on TB diagnostics, especially those that could be multiplexed. And this is a relatively technical presentation. I'm going to go over the material quickly because we're behind schedule, but you will have access to these slides so you can look up information later. So one of the first things that everyone needs to know when considering which test to buy is that the Global Fund has specific quality assurance requirements. And for the TB diagnostics, they must be approved by WHO or by the Global Fund's Expert Review Panel for Diagnostics. And for the SARS-CoV-2 diagnostics, they must be either on the WHO emergency use listing or approved pursuant to an emergency procedure from one of 5 countries listed here. You'll see at the bottom of this slide 2 links to Global Fund pages where you can see the comprehensive lists of TB diagnostics and SARS-CoV-2 diagnostics that can be bought with Global Fund money. So this comes to 5 technologies that are of particular interest for multiplexing for both TB and COVID. There's the Cepheid Gene Expert, Abbott's Real-Time, Roche Cobas, BD Max, and Molbio TrueNet. All 5 of these platforms have TB tests that are WHO recommended. For the Cepheid, Abbott, Roche, and BD Max platforms, they meet the Global Fund's quality assurance requirements for the SARS-CoV-2 tests, either being on the WHO emergency use list or approved by one of the national regulatory authorities. The Molbio TrueNet test, they've applied to the WHO emergency use listing process, and that review is underway. So for countries that are interested in pursuing the procurement of near point of care tests, meaning in particular the Cepheid gene export or the Molbio TrueNet, it would be a good strategy to use generic language in your proposals, so that if the Molbio TrueNet COVID tests becomes approved in the coming weeks, then you would have the option to buy the Molbio TrueNet instead of the Cepheid gene expert. A few comments about the TrueNet test. If you were not on the SLAP TV mailing list, we announced last week that it's now available for procurement through SLAP TV's GDF with access pricing. This is, of course, a battery-powered test that can be used with minimal infrastructure requirements, and it can also be transported with a suitcase. The pricing that's been negotiated by GDF includes the workstations, so that's the equipment required. And you can see here the Uno 1-chip port, the Duo 2-chip ports, or the Quattro 4-chip ports, and the prices. GDF was able to negotiate volume-based discounts. So as soon as 100 instruments are procured, then the price goes down. So for the Duo, already we have a commitment from USAID to buy over 100 machines. So that means the Duo price is now going to be $10,900. And just to compare, the throughput of a Duo 2-chip instrument is relatively similar to a Gene Expert 4-module instrument. The tests for both the MTB and the more sensitive MTB Plus tests are $9. And for every 100 TB tests that are bought, you will receive 20 tests for rifampicin resistance for free, and it's a reflex test. There's also comprehensive warranty packages that were negotiated. These include the repair and replacement of parts, as well as on-site visits. So this is actually a significant improvement over what Cepheid offers. So we hope that makes a difference in countries. And also just to note that we published last week also this SLAP TV USA GLI TrueNet implementation guide, where you can find all sorts of useful information about how to adopt and roll out the test. For countries interested in buying gene experts, it's important to be aware that there are now what are called 10 color module instruments that are available. These are modules that are required for running the Expert MTB XDR test that detects resistance to isoniazid, fluoroquinolones, second-line injectables, and ethionamide. So there are 3 options for countries to buy these 10-color optic modules. You can buy new machines. The price is here. It's essentially $2,000 more than the traditional 6-color optic module instruments. You can connect a new satellite instrument to an existing Gene Expert. So the price is a bit lower there because you're not receiving a computer with it. Or for an existing instrument that has the 6-color machines, you can buy new 10-color modules for $3,860 each. And then you can convert all of your modules to the 10-color ones. You can't have, for example, 1 or 2 10 colors and the rest 6 colors. Cephid's not supporting that. And then the existing 6-color modules can go into your national stockpile. Cephid won't buy those back. It's important also to recognize that there are requirements for the computer hardware. So some of the older instruments came with computers that run WinXP. So those would definitely need to be replaced. And Cepheid is recommending replacement of computers that run Windows 7 with the new computers that run Windows 10. And the prices are here. The other three instruments that were on that table that I shared earlier are what are called by WHO medium complexity MATs. Medium complexity based on their needs for infrastructure and for HR. WHO will be issuing recommendations about them in a few months over the summer. And these are tests that are high throughputs, automated, and they test both for TB as well as resistance to rifampicin and isoniazid. Many countries are already using the Abbott real-time and the Roche Cobis instruments for testing for HIV, viral load, or EID. And you can see the batch sizes here are quite large. These are clearly centralized tests. So as Mark had commented in his presentation earlier, for countries that are interested in increasing access to communities in more remote locations, it would be more strategic to buy either Gene Experts or the mobile TrueNets. Just a few quick remarks, some considerations to make when combining testing for COVID and TB. For multiplexing with existing testing platforms, the advantages are clearly that you can use, you can make use of the unused local testing capacity, and there are minimal implementation and startup costs. The disadvantages here is that you really need to have site level data on the available testing capacity. If you don't, and you make national averages based on utilization rates, then you run the risk of losing some of the important details around which instruments are currently at full capacity and which ones are not. And then there's also the disadvantage of needing to prioritize specimens due to the possibility of exceeding testing capacity on site. For countries that might want to relocate testing instruments, patient access to timely TB testing should be a key factor when considering this. The advantages are that when you relocate machines, you can increase instrument usage rates. But the disadvantages are clear. This can disrupt patient populations, access to timely testing services, as well as the specimen referral linkages. So the preferred solution for ensuring continued access to rapid testing for TB and minimizing impact on existing services is to procure additional instruments, where possible to also expand working hours of staff. The advantage here is clear. You can increase access to testing for all diseases without impact on the existing testing services. And the disadvantage is that additional budget and human resources are clearly needed. So this is the potential for the Global Fund funding to step in here. And then lastly, private sector engagement is important, and private sector sites that meet national quality assurance standards in mapping of existing instruments should be included in those mappings to be able to test for both TB and COVID. And for some private sector sites, the TB programs, the ministries of health can also consider providing free reagents. So this is my final slide. And I'm going to hand over now to my colleague Srinivas, who's going to describe the real world experience of India. Thank you.
Yeah, thank you. Here we are. We have already discussed this bidirectional screening and testing for finding people with tuberculosis early. I'll just share you some of the early experience with from India.
Srinivas, we can see your slides. Can you share again? Yeah, now we can see here. If you can put it in presentation mode.
The slides now? Can you see the slides now? Can you see the slides?
Go ahead. Go ahead.
Okay, thank you. So, as earlier, this is the sudden drop in TB notification, which was recognized very early in India. And as a response to this drop in the TB notification, they developed a recovery plan, a catch-up plan much earlier. And one of the important component of that particular catch-up was the bidirectional screening and testing. It's also important that with the data available, once you know the COVID status of the TB people with tuberculosis, now they have a cohort of patients is more than 600,000 people, and you get that people with COVID, the TB death was more than 3 times. So this is extremely important, and again, we would like to make say a big thanks to India's national TB program, and this data is under publication. So it means that you need to diagnose, just like what we are talking about, the TB, HIV. If a person with the tuberculosis also is with has got COVID infection, then the chance of that higher adverse outcomes are more in that particular group of people, and they need better care. To know that, you need to test them. So that's where one is about testing all TB patients diagnosed for COVID, and also those who are COVID positive, test them, screen them, and test them for TB. This is possible. That is the first thing, is that is it possible bidirectional TB COVID screening in India in large program setup. They have done the verbal TB screening among all COVID-19 patients using the 4-symptom complex. And if they have got any risk factor for tuberculosis or any of the TB symptoms are present, then they were subjected to rapid molecular diagnostic testing. And also all the diagnosed TB patients or the patients on treatment were tested for COVID. In the year 2020, they were able to identify, around 24% of the people with TB also know their COVID status, and of which around 0.9% were co-infected. However, this intervention has happened in the 4th quarter of 2020, but by January, February of 2021, this proportion has gone up by 44%. It really shows that if it's not a very difficult thing to achieve, and it is possible, and as of March, this proportion has gone up to more than 70%. Here is another set of good data, which has come from, again, a routine program. This is from the state of Kerala in India. They were doing systematic active TB case finding. A number of interventions were done during this the COVID pandemic to catch up. That included active case finding with in one population for tuberculosis, and so there was one active case finding again using chest X-ray, symptom screening, chest X-ray, and rapid molecular diagnostics. And the other one was active case finding going into the people under palliative care or bedridden elderly people, and all the third one is that going into the old age homes. At the same time, they had this active TB case finding among people who presented with the about sudden acute respiratory infection. These are the common symptoms for COVID. As you can see that the last interventions were yielding a lot of good number of TB people. The diagnosis, the yield per 100,000 people screened was quite high in case of SARI and also on ILI. And it's also possible to, you can actually see that at least around 7% of the people with the influenza-like illness, they had symptoms suggestive of tuberculosis. That means they were presumptive TB patients. And when you do, rapid molecular test, about 3% of them were positive. However, of SARI, 14% of them were presumptive TB, and 7% of them was positivity rate among them. So these are two interventions. That means that if the people you actively search for tuberculosis in those people presenting with symptoms of COVID, and there's a chance of finding tuberculosis and also finding tuberculosis early. This is just the rapid increase in the rapid molecular diagnostic sites and also the tests done in India compared to 2019 and 2020, and even this year 2021 there is still it is getting nearly
so Srinivas, your voice is getting interrupted. Can you switch off your camera and try speaking?
I am done actually. This is the last slide. Thank you.
Okay, thank you, Srinivas. So at places you were kind of fading out and in the audio, but I think people were able to get the message in the slides. We have to now move to the next presentation, which is on contact investigation. This is another area of focus, and to take us through will be Sevim from USAID. Sevim, please go ahead. Srinivas, if you can stop sharing the screen so that Sevim can share his screen.
Thank you, Sahu. Hopefully today this will work since we had some difficulties with the sharing yesterday.
Yes, we can see you.
Okay, thank you. Let me start from the beginning. Thank you very much, and good day to everyone, and thank you for everybody who joined this presentation today. So this this part of the webinar, as Sahu mentioned, will focus on the integrated contact investigation response for TB and COVID and COVID-19. The previous speakers, it was mentioned several times how contact investigation fits under the current objectives of the C19 RM, and really we look at the contact investigation interventions and addressing the three main objectives of that of C19 RM, both in terms of providing a solid response to COVID-19. In terms of the detection and testing for COVID-19 patients, as well as really having a very strong impact on the mitigation of COVID-19 impact on TB prevention and care. As well as TB case finding, as was previously Sahu showed at the beginning of the webinar, the devastating impact that COVID has had on the TB notifications and TB case finding in general. And on the third side, on the third objective, contact investigation interventions are really critical in strengthening the TB program's capacity to respond to COVID-19 through optimized resources and building search capacities. And in that objective, also of course, is strengthening of the community responses and health system responses in the countries. We in terms of the critical part that contact investigation can play in this response. We do have already quite a lot of lessons learned from ongoing contact investigations, And the platform, the contact investigation platforms that are built on the TB clearly can add value to the COVID-19 response, to be able to mitigate both the impact of COVID-19 on TB, advance the response to COVID-19, as I mentioned, but also very critically thinking about the future strengthening of these platforms through the integration of TB and COVID-19 contact investigation efforts, also build and strengthen this platform for future airborne pandemics and pathogens that we know are also coming, and we need to also be prepared for those future emergencies. Similarly, the implementation approach to integrated TB and COVID-19 contact investigation is included in the Global Fund information note, as well as it is linked through the Stop TB partnership website. But the approach the implementation approach consists of three main prongs, so to speak. One is we're looking at the entry level being through the community and the household. As we know, in terms of our already established approach to TB contact investigations, the activities and interventions addressed at the household level. The second prong is looking. We also know that contact investigations, some elements of it are also conducted at a health facility level, and there's also opportunities for integration of COVID-19 and TB screening and testing and health and at health facilities. The third element that is really critical, and my colleague Amy already mentioned that, it's very important to have the integrated sample referral and diagnostics, that we use the opportunities as the screening is happening for TB, as well as for COVID-19, but we'll also utilize these opportunities to collect and specimens on site as possible. It is very, very important having both the community-based interventions and the health facility-based interventions to have a very systematic approach and strong linkage established and built between these community and facility-based contact investigation interventions. We know that without such a systematic approach, the integration of TB and COVID-19 activities will not be as effective and as efficient as we would like them to be. So in the implementation approach to integrated TB and COVID-19 contact investigation, we have included two specific illustrative algorithms. As I said, starting with TB and COVID-19 screening and testing at the household level, using the opportunity that those interventions should include screening households for COVID-19 symptoms, as well as following up on the algorithm and also screening and further evaluation for tuberculosis disease, given, as it was already mentioned, the similarities between the two diseases in terms of having similar signs and symptoms. And again, to reiterate, if possible, this provides an opportunity. I know in some countries the collection of specimens, diagnostic specimens, is happening on site, but this is not the case in all of our countries. But in terms of having an effective response and an effective integration of these interventions, it is critical to consider the field-based collection and integrated sample referral of blood, sputum, and other specimens that need to be obtained and sent for further testing. The second illustrative algorithm that we have included in the document is the facility level contact investigation and COVID-19 screening. So it is important to have the systematic screening for active TB and COVID, and it should be implemented among all persons who are seeking health care upon entry to the health facility. Really to having that integrated, use the opportunities through the health facility entry points to do the screening for both TB and COVID-19, and then promptly triaging of individuals with signs and symptoms, and those should be based on the WHO-defined symptoms criterion, respiratory or flu-like COVID-19 symptoms with specific temperature checks. In addition to these algorithms and that we have included, another resource document is the costing templates to help countries estimate specific costs associated with the integrated approach to TB and COVID-19 contact investigations. So what you see on the screen is just an example that we have used from India in this instance, and it's a streamlined template with inclusion of some major costs that are related to diagnostics, to testing, drugs, as well as very critically, we have included estimates for human resources, the need for human resources costs, both at health facility levels, but very critically also for community-based interventions. In addition to that, the COVID testing costs, as well as chest X-ray estimates for chest X-ray costs, which are very important to have in the diagnostic algorithms for screening and testing, as well. And just to say that in terms of the template, the structure of the template, it is some of these estimates are based on assumptions. For example, what proportion of identified contacts can be screened at a country setting, as well as costs assumptions related to the tests and the chest X-rays and the other equipment, and also that it provides different scenarios whether, for example, the screening algorithms of contacts will include testing for TB infection, for example, and use of shorter regimens, and so on and so forth. But just the main point here is that these assumptions are built in, and they can be changed and adjusted based on the specific country situation and feasibility of implementation. And this costing template is also available and will be shared. Finally, just to wrap up, what are the available resources, since this is really focused on what can we do to speed up and develop good applications for the C19RM process. In addition to the COVID-19 contact tracing and TB contact investigation, this integrated implementation approach document that I mentioned, and went briefly over the two specific algorithms that are proposed in this document. We also have developed a programmatic implementation of TB contact investigation document. It is a much larger document focused more like implementation manual for TB specific contact investigation, but I think that document would be also very helpful as we are scaling up these interventions, and that document is also available through our USAID site, as you can see on the link is also on the screen. And thirdly, as I mentioned, the costing template to assist with estimating of the integrated TB and COVID-19 contact investigation activities is available as a separate document as well. Thank you very much.
Thank you, Sevim. So now we go to community interventions. It was interesting to see a chat there about community-led intervention stigma. And we will have Viorel Sultan from Stop TB Partnership. Viorel, please go ahead.
Thank you, Sahu. And Sevim, if you can stop sharing your screen so I can do from my side. Thank you. Okay. So we heard from Lucica Sherry and Mark Eddington earlier about the importance of the engagement of TB communities and civil society in the C19RM and the TB response. My name is Viorel Sultan. I'm head of the country and community support here at Stop TB, and we'll go through quickly through some resources that will help you to build a successful application to the Global Fund for that. So in 2020, United Nations Secretary General issued a report in terms of progress on reaching the global TB targets and commitments, and basically stated very clearly that COVID-19 should be mitigated in relation to TB response at the country level. And we also, and you, a majority of you participated in the complementary monitoring report by the community called the Deadly Divide, where basically we said that COVID-19 should be used as an opportunity and not as an excuse that we cannot reach those targets and commitments. You have the links there on the slide, and these documents can build, can help you to build a successful application to those activities that you will include in the application. Earlier, Ketivan and Sahu as well mentioned the existing documents that were issued by the Global Fund for the C19RM, and it was a specific COVID-19 response mechanism info node. I would like to stress your attention on another info node, which is COVID and TB catch-up plans. So this is the language in this information node that is also published, developed by the Global Fund together with the partners and published on the website. You can use for building the case and including those activities that are related to the community engagement and civil society responses. So it is about barriers to services, that we have to know them, that we have to address them. It is about establishing systems for social, mental health, financial and nutritional support, sustaining commitment and advocating for them, ensuring inclusive and accessible healthcare. We heard about the diagnostics, as well as engagement of the communities in monitoring and surveillance. In those documents that have been published by the Global Fund, you may refer to the application form, and there are some specific sections that needs to be addressed, and we need to be sure that civil society and TB is part of those. Specifically, it is about section 211, which is the context where we need to include the role of civil society in COVID-19 response, as well the stakeholders engagement, and we need to be sure that the TB affected community is on the table and engaged. When we talk about the service disruption at the country level, we need to address the key and vulnerable populations, and we know them, those that are linked to TB, as well as we need to detail human rights, stigma, and gender-related issues and barriers. And a majority of you already participated in CRG assessments, as well as developing the country action plans. So please use them in building the application to the Global Fund. Also, you will find on the web page a specific modular template. And I would like to mention few modules that are very important for all of us to include community and civil society participation. There it is about case management, and it is about community activities that outreach and closer to the people. And just to mention that even you can include the payroll for additional personnel engaged for this. So it is about mitigation of TB with meaningful engagement of community and civil society, gender-based violence. We need to be sure that TB and women from key and vulnerable populations linked to TB are part of those human rights, stigma, and gender assessments. Capacity building, and of course stigma measurement and reduction, community-led monitoring that we already know very well, community-led research and advocacy, social mobilization, capacity building of networks of people affected by TB, and civil society. So all of them are part of this modular template. Please use them when you build the successful application to the Global Fund. Also, I would like to mention that there is a possibility to apply for above allocation request. Please use this as well in addition, but don't move everything which is community and civil society to above allocation. This is not right. We need to be mindful to cover this in both parts. Next few slides, just to provide you with additional resources to build a successful case. All of you participated in earlier in civil society and community perspective around TB, how much COVID affected TB. Sahu already mentioned, I will not stop here, but just to let you know that there is a resource that you can use to build your case. Also, Srinivas earlier mentioned, and I put in the chat, there is a specific TB and COVID resource on our website of the Stop TB Partnership. Please use this in terms of building the case. And finally, I would like to mention that together with all of you, we developed these investment packages for TB responses which can be easily adapted to TB and COVID. Specifically, it is about TB and COVID in prisons. It is about TB and COVID stigma measurement and reduction, TB COVID community-led monitoring, gender, as well as CRG, assessing CRG barriers. So it's easy to use. Please take them, adapt. It's easy to adapt and build your case. It is important that all of us know this. And in conclusion, COVID-19 affected very much TB response. We need to know that the barriers increased and new emerged. TB community rights and gender is central to the information node and should be part of the application to the Global Fund, and the existing investment packages are relevant and can be easily adapted to COVID-19 application. Thank you very much, and I'm turning back to you, Saho.
Thank you, Viorel. We now go to the last presentation before we open up for a few minutes of discussion. But keep the questions and comments coming in the chat. This presentation is about the USAID technical support that is available for proposal development, which is very important coming to the real work now to be done by countries. So we have Alex from USAID to tell us about this. Alex, please go ahead.
All right. Thank you very much, Saho. I hope you can hear me and you can see my slides. Good. Welcome everyone to this webinar. As Saho mentioned, my name is Alex Golubkov. I'm a senior TB advisor at USAID Washington TB division, and I'm one of the persons that is who's managing the short-term technical assistance (STTA) at TB division. So today I have just a few slides to present how USAID can support you guys, NTP, Ministry of Health, and CCM members with application to the Global Fund for the C19RM applications. So first, let me just mention that and show on the screen a list of countries. It's a pretty large list of countries where USAID working and we're providing technical assistance. There are two different lists. The first one, what you see, it's USAID countries where USAID has TB bilateral programs. It means that USAID missions receive funds on annual basis and program those funds in countries, in those countries that is listed on a screen on the first group of countries. And we do have active TB projects, activities in the countries, as well as we do have USAID staff in USAID missions in those countries who are responsible for TB. And then if you are based in those countries, you know your colleagues from USAID, you talking to them probably on a daily basis, so you're very well aware of that situation. Second group of countries at where USAID is working, but we do not have TB programs in there. We do not have TB money in those countries. However, those countries, they do have USAID presence. Some of them, they have USAID health activities. Some of them may not. Some of them may have different activities. But still, we as a TB division, we're responsible for providing technical assistance for TB to those countries related to Global Fund. So it's actually the same applies to the C19RM. If you are in those countries, the second group of countries, you are also can request and utilize assistance from USAID Washington for this support for the Global Fund. And then, as you see, total we have 55 countries that we are working with providing technical support. So for the Global Fund, the COVID response for the C19RM short-term technical assistance STTA, the goals and objectives. The goal, of course, is to mitigate COVID-19 impact on TB programs Objectives is to support, assist CCMs, NTPs, you guys, Minister of Health, with application to the Global Fund, support countries to develop related strategies, policies, guidelines related to COVID and TB, and of course, assist and help with implementation of those grants and programs to achieve goals and targets set in the application. This is the most important slide. It describes the steps, how to engage, how to get support, how to get technical assistance for this Global Fund COVID response funding. The first step is for CCM or NTP or Minister of Health. You have few options on how to start, how to engage, how to initiate this technical assistance request. If you have USAID mission in a country where you have your partner, you have USAID colleagues in the mission. Is if you are based in the country where we do have USAID TB presence, a TB project, the first group of countries that I showed. It's the easiest way for you will be to just to contact your USAID colleagues at a mission and ask for technical support, for technical assistance. Or you can go directly to Stop TB Partnership, or the last option is to go directly to USAID Washington. And for that, you need to send email to this email address. It's on the screen. If you do not have USAID Health Office, if you do not have in your country USAID TB project, in this case, of course, you can just go directly to Stop TB or to USAID Washington in this case, and I will read it out for you. The email address is usaidtbta@usaid.gov. So that's email address in red. That's automatic email address. What it means that once you send email, very short, just a 2 sentences email to this email address, you'll get automatic response from this system with a link to a Google form, and that you need to click on that link and then fill in the UTA request. It's a very short form, maybe 1 page long, takes you maybe 5 minutes to fill in the request. The form will ask you what country you are from, what type of support you need, what dates of the support, just very basic questions in the language of the consultant that you're looking for. And once we get that form submitted to us, we monitor those forms and emails on a daily basis. Once we have that form coming to us, then we will start engaging with you. And depends, again, if we do have USAID presence in the country, we will work with USAID mission and then supporting you. If not, we will work directly with you from our headquarters. So once that TA comes to us, to TB division, we are analyzing those TAs, as I mentioned, at our STT team. We have a pool of consultants specifically selected for the Global Fund application for this a round of C19RM applications. We just had a kind of briefing like this webinar for consultants just yesterday. So we are, based on the country request, based on the specifics of the request, we're looking at, we're selecting a few candidates from that database that we have together with Stop TB. And then we communicate back a few options to you guys, to the country. And again, it depends whom we're talking with, if it's USAID mission or it's NTP or it's CCM, doesn't matter. But at the country level, I think it's already been mentioned by Sahu, by other colleagues, that because it's a joint request by country together with all 3 diseases, CCM and COVID response team. So it has to be somehow kind of managed and organized. The same as selection for technical assistance has to be organized in that way. So once you country received few options from us, then we will receive names and CVs of the consultants. You will have a chance to review them and then select the best that you prefer. You can interview those consultants if you like to. You can send them an email and discuss details. Feel free to do that. And then once you select them, you will inform us, and then we will ask a hiring mechanism, hiring project that will actually hire those consultants and then deploy to you. I will talk about that a little bit later in the next slide. So once a consultant is deployed in person or virtually, then it's your consultant. We are no longer involved in that process. It's your consultant. Please work with your consultant on a daily basis. Communicate, work together, set deliverables for consultant, monitor his progress or her progress, engage consultant with all partners. If we have USAID mission in the country, please engage USAID mission as well, because as I think it was mentioned this morning, at the beginning of the webinar, is that USAID is will receive separate COVID funds, which will go to missions. So in order to kind of avoid duplication and make sure the response is coordinated, USAID funds and Global Fund funds for COVID, it's important for USAID mission to be involved in those discussions when consultant is helping country. And then once the technical assistance is finished and the consultant finishes with his report, then we will follow up with the country, with you guys on a quality assurance. We will send you a quality survey asking for your experience and asking for your recommendations and feedback, so that we can improve technical assistance. So and then in terms of like projects and mechanism and pool of consultants, as I mentioned, we have consultants selected for the Global Fund application processes. Most of the consultants have experience writing Global Fund applications. We have two mechanisms that we will use to hire consultants. One of them is, of course, Stop TB partnership. Stop TB partnership has a lot of consultants on the roster that's supporting Global Fund, supporting MDR TB response, supporting TB response, content investigation, of course, consultants involved in GDF work. So all kinds of consultants. And we hope that your request we will help you with your request for support. Also, we have consultants we hire through USAID project. It's called GH-TAMS. Some of the consultants will be kind of employed through that project as well, in addition to Stop TB. And lastly, just to mention that it is possible for a country, for CCM, for NTP, for you guys to propose your own consultant. That's also possible. Again, because of the COVID times, consultants cannot travel, and of course, it's preference for a consultant to be based in the country and supporting country on a daily basis. And ideally, having access to data, having access to our partners, having access to COVID response team. So feel free to also propose your own consultant. That's fine. Ideally, you would have some kind of selection process at a country level when you will review a few applicants, few consultants, and select the best one. And ideally, you interview the person before you proceed and share the name and email with us. Once it's done, we will, of course, ask Stop TB or GH-TAMS to hire a consultant, and then he will be deployed. The only downside is that because it's a new consultant to us, it will take 2 to 3 weeks to hire the person. In this case, it's a new person. So because of turnaround time is very short for the application for Global Fund, make sure you start this process very soon, like today, tomorrow, and then kind of stay ahead of the game, select consultant and share the name very, very quickly. So then it takes, because again, as I said, it takes time to bring a consultant on board in this case. So that's it. That's my last slide. I'm happy to answer any questions if you have.
Thank you, Alex. So that is all that we wanted to communicate through the series of presentations. Simultaneously, we also saw the chat quite active, except maybe for the last few minutes. But if there are any pressing questions which are not already in the chat, maybe you can go ahead. We will just keep maybe 2 minutes to conclude at the end. We have about 5 minutes, maybe 1 or 2 comments or questions. I don't see any hand raised, or you can just unmute and speak if you want to. Please go ahead. No, so I don't see. So let me try to conclude, and I'm not sure if Sherry is also on the call. Maybe Sherry, if you can also say something at the end. So let me try to conclude a few things. Number one, I think we have to be very clear, and I wanted to mention this because I saw some chat also. Eliud and I think Luchika also in the beginning made it very clear that there are 3 objectives in the C19RM. And this is actually on page 7 of the document, which is information note on C19RM. You can see those 3 objectives very clearly. The first objective is COVID-19 control and containment. The second objective is mitigation on the of COVID impact on the 3 diseases, including TB. And the third one is health and community systems. So TB can be articulated very well under the second objective, but will also connect to the first objective and third objective as we discussed. So that's number one. Number two, we discussed a number of interventions. I saw colleagues, thanks to Mohammed, Yasin and others, the information notes that were developed was done through a lot of consultation, and country experiences were also taken into account. But of course, they have to be, it is very high level. It has to be adapted to the countries. Very important to be strategic. And some things that were mentioned in the opening, let me just repeat it. Very important to see that at least for TB, we see that the diagnostics linked to this bidirectional or integrated, simultaneous, whatever you call it, that needs to be in there. We need to ensure that the contact investigation, both COVID and TB, needs to be in there. The PPE for both COVID as well as TB health and community workers, and the infection prevention and control IPC, airborne infection, need to be there. And we also heard about stigma and community interventions need to be there. There are also many other things that can be there depending on the setting, but we should ensure that at least the high priority ones are there. We have tried to present all of these in the presentations. The presentations will be shared because the chat was quite rich. We will also maybe try and translate that into French and Russian and send it out because it was only in English. So that's on the intervention piece. Now, 2 other things I wanted to quickly mention. One is the ambition level. The ambition level has to be set at the right level. We should be able to recover. You saw the impact, unprecedented impact, disproportionately higher impact on TB. Many words were used to describe it, and you all know it better. So how can we plan something which is ambitious? You heard in this context that 15% is the base allocation. Countries which are ambitious and are able to propose good interventions and absorption is good, they will be able to get more money. So above allocation is important. So ambition level is very important. Number 4, the last one from my side, is speed. I think Alex made something in his last slide saying we should start this request for support tomorrow or day after. And that's the speed that we should be following, because as you heard many speakers say, this is an emergency mechanism. Even this webinar was nowhere in the planning till last Friday and was constructed over the weekend and on Monday. And thanks to all the speakers who agreed. And I think that kind of speed is very important. So I would end there, but I would also like to thank all the participants who joined on short notice. I know people are busy, but this is an important opportunity. I want to thank all the speakers who had to accommodate their what they wanted to speak in the timing that we had, and also the colleagues that were not speakers but were responding to chats, and I think many things got answered in the thanks. So thanks to them. And two other groups, the translators. I haven't heard the other languages. I hope it went through well. We must thank the translators and also thank Ricarda and Mohammad Anwar, who are in the background organizing the webinar. So, so that's all from my side. Sherry, would you like to say something at the end now?
Yeah, I mean, I think everyone, we're closing now. I just like to thank you for your attention and all of the questions. I urge you to when we say ambitious, put forward the request. Let them say no. There is lots of money put on the table, and this money needs to be spent quickly. The timeline is, I think, in the next 2 years. So I think we need to put that forward and challenge that it can't be funded for one reason or another. I think everyone's saying they want to support all of these activities, so don't be shy. And then it'll get worked out in the final submission from the CCM. So thank you all, and I'm really excited. Please reach out if you need any assistance whatsoever.
Thank you. And
have a good evening.
For now.
Good afternoon. Bye.
Thank you.